very welcome, Jason.
Okay, thank you very much for the introduction. So as introduced, I'm Chartered Psychologist. I'm not a clinician by background. I'm just going to throw that out there straight away. I don't have any clinical expertise, but my expertise really within psychology, looking at the quality and safety of healthcare. And today, what I'm going to talk about is two different strands of research that I've been doing. And I was just saying to Aoife beforehand that when I started creating this timeline, it was actually quite daunting when I wrote the first number on there, 2009. It means I've been doing this for 10 years now. So I can say that I've been doing research for decades, or a decade anyway. But yeah, so essentially this presentation, what I'm going to be talking about are two different strands of research. One of them is looking at essentially patient experience of safety within care transitions, particularly looking at around the discharge process and post-discharge care. And then the second strand of research, I'm going to be talking about pre-hospital care and how I've been involved in service improvement and research around pre-hospital care, particularly related to frequent callers to ambulance services. And so essentially, frequent callers to ambulance service, I will talk a bit more about it shortly, but people who call the ambulance service up to 1,000 times a year in England, so 3 times a day on average. And it is a huge problem, but also one that's quite under-researched. So first part of the presentation, I'm going to focus on post-hospital stuff. And then the second part, I'm going to focus on pre-hospital care. So this goes back to essentially when I started my PhD in 2009, which looked at what patient perceptions of safety look like when people are going through care transitions. And when I'm talking, I'm going to be assuming some level of knowledge amongst people related to what patient safety is at the moment. And then, so moving on from PhD, we then got some research funding to look at a feasibility study looking at implementing a safety survey for people to report on their safety experiences. And then tied into that, we looked at what clinician incident reports look like related to transitional care, and then where we are at the moment with the research, looking at transitions from hospital into the care home. So very quick bit of background. Within the UK, we had huge, we had what the Mid Staffordshire inquiry. We looked at failings within Mid Staffordshire NHS Foundation Trust, and it was a huge scandal in the NHS. Numbers are still quite uncertain, but it was about 800 people to 1,200 people roughly died needlessly whilst in the care of the hospital. And as a result of that, we came out with Francis Inquiry, who's QC, as well as Don Berwick, who looked at interpreting Francis Inquiry. And what they both called for was the great involvement of patients at all levels of healthcare. Now, when it comes to patient safety, first of all, I should say that patients, when we speak to patients, they often define safety very differently to our standard approaches to doing so. So from what clinicians would tell us, or as we looked at from a safety science perspective, then patients talk about safety very differently. There's some crossover, but it's not entirely aligned. So patients define safety differently. And so what that means is that when we're asking patients to contribute to our knowledge about patient safety, for example, if we're asking them to complete a survey, then there's two different ways of doing so. One is through asking patients to incident report, which is the same way we do with healthcare professionals, and it's very much a case that they are reporting on something which has gone wrong with their healthcare, and the idea is that we can learn from that and improve the systems around it. The second way, and it's the second way that I've focused on mostly within my research, is that we ask patients to report on their experiences of safety. And they're two fundamentally different things. When we talk about the experiences of safety, we're working on the assumption that somebody who's receiving care may feel unsafe, but it doesn't necessarily mean they are unsafe. And this is something that I've had lots of debate about, particularly in my PhD work, where I remember we went to the ethics committee to get approval for the work. and there was an anaesthetist sat on the ethics committee, and he said to me, but every single one of my patients feels unsafe. I know they're safe, so what does it matter if they feel unsafe? And there's a really experiential aspect to that, in that it is one of the pillars of quality within the NHS in England, that patient experience is seen as an essential aspect of quality. So therefore, the same can apply, I would argue, to patient safety as well, particularly if we start looking at it at a large enough scale. So yes, if we ask one patient about their experience of safety, they may tell us, well, yeah, I didn't feel safe, but they may have been objectively safe. But actually, if we ask enough patients, if we do this across the board, then the theory is that we should be able to identify trends and patterns that align to different safety metrics. And that's essentially the premise of this work, of what we're working towards. Now, there has been some research that's looked at what patients can tell us about safety. For the most part, it's generally done within one particular clinical setting. So patients who are on wards in particular. There's a lot of work done by the Yorkshire Quality and Safety Research Group. They looked at patient incident reporting, where they essentially went around the wards, a lot of research nurse support as well to do so, asking patients face-to-face using a survey whether they could report on any safety incidents. So it is very much incident reporting as opposed to experiential reporting. But it becomes even more challenging when we look at care across different across transitional care. And what I mean by transitional care is when patients move from one organisation to another. And I'm particularly interested in those organisational transitions, particularly when it comes to safety experiences. So this model, which I've put on the right, and this is why I say there's going to be an assumption about some prior knowledge about patient safety. One of the key theories related to safety science is called the Swiss cheese model. Very briefly, what it does, it explains how risk can result in harm to patients. And the idea is that hazards exist within any healthcare setting, within any setting, actually, not just healthcare, applies to all sorts of different industries. But the idea is that those hazards can be actualised. And what we can do is set up different sorts of safeguards, defences and barriers that stops those hazards from becoming losses, as the terminology uses. So, for example, we can put in place checklists. That's one sort of defence. If we use a checklist prior to surgery, then we will stop a hazard, we'll stop wrong site surgery, in theory. But no matter what barrier we put up, no barrier is perfect, no defence or safeguard is perfect. They all have little holes in them that constantly change. That's basically the underlying theory. That's James Reason's Swiss cheese model of safety. So going back to the PhD work, we interviewed service users who'd recently gone through a care transition, asked them what safety meant to them. And what they told us is that, yes, a lot of the traditional safety issues came up. So things like hygiene, falls, medication. But they also talked a lot about communication, the importance of responsiveness of healthcare professionals, which is how the healthcare professionals essentially respond to the individual person's needs. And so what we theorised is that patients themselves can operate as an additional safety buffer. But an essential part of James Reason's Swiss cheese model of safety is that we can put in place different barriers and defences, but because none of them are perfect, we have to identify where those flaws are, where those holes within the existing systems. And for that, we need instant reporting as one of the ways of identifying where the systems don't work properly. So moving on from that, what we started to do was ask a question around how can we involve service users to report on their safety experiences, so that we can collect that data that would hopefully lead to service improvement. So again, this was part of, or some of it was part of my PhD, I should say, the initial development of a safety survey. Very briefly, what we did was we worked with both service users as well as clinicians, people from various different sectors, including ambulance service, care homes, and community care teams, as well as hospital staff. And what we did was we set out on a process of co-design. So when we started, we had no expectation whatsoever of how patients can give us feedback on their safety. And what we did was we asked for participants to, first of all, think outside the box, which is essentially this divergent thinking. From the psychology behind it is that everybody's got different schemas or different understandings of the world, and what we want to do is break people out of those existing schemas or the valleys that they think in. And so we considered various different approaches, some of which were quite standard. We looked at checklists and how patients could be involved in that. We looked at using sort of letterbox schemes. We talked about how pilots report. We talked about how postal services currently convey information and experiential data. So huge different amounts. And then we brought that back together. And the consensus was that we would go for a survey approach. One of the underlying reasons for that is that when we're looking at transitional care, looking at people moving between different organisations, we need to be able to try and follow them across. Now, bear in mind that the NHS, particularly now within England, it's not very integrated. We have multiple different providers, some of them private. We've got care homes who are all privately run by hundreds of different providers. So essentially what we want to do is try and make the patient the centre of that transition. So we designed this survey, did a little bit of pilot testing, and the way we designed it, very briefly, is that we asked patients around 3 different stages of a transfer, around the departure or the discharge, the journey, and then the arrival or the admission and wherever it is they're going next. We asked them about 6 different domains of safety, communication, responsiveness, those 2 that were picked out from the patients themselves, as well as delays, falls, medication and hygiene. And we kept it to a 3-point Likert scale, safe, neutral or unsafe. Then what we did after that, so we got some research funding, which was from the Health Foundation, which is a charitable organisation in England. And the funding was to essentially do some feasibility testing around using the survey in practice. And that feasibility testing looked at 3 different parts of it. One of which was testing the limited efficacy of the survey. Does it have a potential to give us the data that we need? Second part was around determining the acceptability of the survey to patients. And then third part was looking at the integration and the acceptability amongst staff of using the survey as well. So in terms of the limited efficacy part, we looked at what we want to do is trying to measure patients' experiences related to the discharge from hospital. And we also collected data on staff incident reporting with a matched time period as well. The staff incident reports, I'm going to talk in detail about that shortly. I'm going to give you the findings of the rest of the feasibility first, because some of the results from the staff incident reporting is quite fascinating in itself. And then the second 2 parts, we used essentially qualitative methods to look at that. So in total, what we did was we worked with 16 wards across 4 different clinical areas in 4 different hospitals. And there's 2 different NHS trusts, if you can follow and create that pattern in your mind. We essentially looked at care of older people as a general theme. So we looked at cardiac wards, care of older people wards, orthopaedics and stroke. And then we interviewed 28 patients and 21 of the staff who were involved in distributing the survey as well. And so what we did was we distributed almost 3,000 surveys in total. There were roughly about 11,000 discharges across the study. Now, the original aim was that every single patient should be given a survey, regardless of whether they had the capacity to complete it, because it also invited their primary carer, relative, family member to complete on their behalf. So every single discharge should have received a copy of the survey. So you see already it was about 20%, give or take a little bit, that actually did receive the survey. The way that we went about with distribution is that each of the wards would receive a pack of numbered surveys at the start of every month they took part in, and we did this for 2 6-month periods. And what we would do is we would monitor distribution rates by the number of surveys that were handed out. So from those we had 452 survey responses. Not all of them were valid, and I'll talk to you a little bit about that shortly. As well as, I've said we've got 92 Datex incident reports. They're the incident reports relating to patients' discharge. The actual search of the incident reporting system provided over 300, it's about 350 incident reports. The majority of which weren't relevant for this study, but we did look at them in a lot more detail, and I'm going to talk to you about that shortly as well. So in terms of the findings, first of all, limited efficacy. What we found is that the respondents, first of all, were generally representative of the different clinical areas. So when we looked at who the respondents were in comparison to the discharges amongst those wards, they were generally representative. Now that was quite pleasing because we didn't manage to reach every single patient discharged. A large number were missing. So we were a little bit concerned that there was some inherent bias within the distribution of the surveys, which would have been telling in itself. But generally there wasn't. There was one exception, which was care of older people, where respondents tended to be younger and tended to be female as well. And what we found, so this one's probably a little bit hard to read. We looked at whether the clinical area, the age and the gender of participants had any relation to the safety ratings they provided. And what we found is that there wasn't. So none of those characteristics were actually influential based on the incident reporting. And in terms of what people actually told us about how safe they felt, then across the 6 different domains, what we found is there's quite a clear message within the delays in particular. A huge issue around delays related to discharge. And participants, as well as the interviews, there's also free text comments available in the survey. Participants expressed that quite clearly in the interviews as well. So at 9 o'clock in the morning, surgeon came around and said, okay, you can go home. 12 o'clock came, they're still there. A lot of the stories we heard were around discharge that was delayed, where patients being told, you'll be able to go home soon, but actually they then missed their meal times, they haven't ordered a meal, they thought they were going in the next hour, they're left hungry, and there's a real issue around quality of care. For a completely personal anecdote, we experienced this recently as well. A few months back when our second son was born, we were told 7 o'clock at night, right, we've just got one little last check to do and then we're going to discharge you and you'll be out of here pretty much straight away. We were still sat there at 11 o'clock at night, still waiting to be discharged with no explanation, and every time we tried to ask somebody what's happening, we were just fobbed off, just said, we're too busy, with no real explanation. And it meant that we'd sat there with nothing to eat for hours and hours. Fortunately, we had childcare for our other son, otherwise would have been quite stuck. So there is a really big issue around delays. And then in relation to how this fits in with what the staff incident reports were looking at, I've given a brief synopsis here. I did have another slide that broke these down into extra details as well. We looked at the incident reports, 92 incident reports, and generally try to group them into themes. And what we found is that the communication failure is one of the themes, medication, there's delayed discharge that was in there, issues around documentation. That one's particularly interesting because it's something that through all of the work we've done, patients have never discussed with us. We haven't had a single patient turn around and say, actually, yeah, my documentation was missing when I was discharged from hospital. Yet we know when we speak to the care homes, when we speak to the hospital staff, it's a huge problem. But it's just a question of whether patients are protected from seeing that, although it still affects their care. Another one was pressure ulcers. That one is another one that's really interesting. But again, I'm going to talk about that when I talk about the data in depth. Remember stuff around devices, equipment, essentially things that were left in situ, where patients were discharged and they still had something left in them that shouldn't have been. Staffing shortages, and then a little theme around patient actions. For example, if a patient self-discharges, even if it's arguably the right thing to do, it's still classed as a safety incident, which I don't quite agree with. So when we look at that in comparison to what the patients have told us, we see that there are some shared perceptions around delays, around communication, around medication, which in a sense it's quite reassuring. It's supporting the data that we collected from the patients, it's supporting what the staff are telling us, and it's giving a clear message that these are areas that need improvement. And then in terms of the themes that we looked at, around hygiene, around falls, around responsiveness, they weren't really picked up in the staff incident reports. But likewise, staff incident reports picked up the issues around documentation, pressure ulcers. So essentially, in terms of the data that the patients provide us, what we can probably say is that I think the conclusion we can reach is that patients can tell us something meaningful about their experiences of safety-related transitions in care. But there's another question about whether patients are actually willing to tell us that. So when they do give us information, give us feedback, then it can be quite useful. But actually there's an issue around acceptability of reporting. So first of all, if we look at just simply the response rates we got to the survey, then we can see that across 3 of the clinical areas, cardiology, orthopaedics, stroke, but actually it's quite similar. About 1 in 5 patients roughly will provide feedback. Now bear in mind there's limitations with the way the survey was conducted as well. So first of all, these are generally people who are going to be unwell, older people, and what we're asking them to do is to return a postal survey to us. It was free post, but even still, we're asking them to try and get out to a post box and put it through and return it to us. So that in itself can be a bit of a challenge. So the 20% response rate, it's not excellent, but given the methods used, I would say it's borderline acceptable, with the one exception of care of older people, where we had 2.6% response rate, which I'm sure everyone would agree was quite dreadful. So, and the interesting part is the care of older people ward was generally even older than the other wards. When we first set out doing the work, when we're speaking to all the ward managers, then there seemed to be a bit of a consensus that actually it would be stroke as a clinical area where we would get no responses. They said to us right at the outset, we'll do it, but you do realise nobody's going to actually return the survey, do you? So actually it was quite surprising that stroke had a decent response rate. We also looked at, so in England we do what's called a friends and family test, which is basically just a very simple question. Would you recommend this unit or this ward to friends and family? And we looked at the response rates to the friends and family test. And we found that there was no correlation at all between the two. And so what we've summarised as a result of that is that quite pleasingly, the patients recognise we're asking them a different question to what friends and family asks. Whereas if they were completely correlated, then it would beg the question of why are you doing this at all? So then we did the qualitative interviews as well, and we looked at essentially what are the facilitators and barriers to patients providing feedback. How acceptable is it to do so? And what we developed is this staged model, where what we argue is that for each stage to be completed, it needs the prior stage to be in place first of all. And so there's 3 different stages to it. There's what's termed the cognitive, cultural, structural, procedural, as well as the learning and change. Now, some of this is quite accepted, it's already quite known within the literature about staff incident reporting. For example, the last stage of the model, learning and change, patients had to understand that their feedback would lead to something meaningful happening. So if they felt their feedback was just going into a black hole, then they were less inclined to provide it. Now, we know that in terms of completing feedback loops with staff incident reporting as well. If we don't give feedback to people based on reports, they won't report again. They won't see the point. So we found the same with patients, which is quite understandable. We were expecting to see that. Probably the most interesting one, for me anyway, is this cognitive cultural one, which it's the first stage of a model, and essentially what this comes down to is whether patients actually understand what we mean by patient safety and understanding the importance of patient safety. And so some of the feedback that we had from the patients is that one of the quotes that stands out to me is when somebody said, well, I go into hospital to get better. I don't go in there to be safe or unsafe. So therefore, safety's got nothing to do with me. So therefore, why would I ever report on my safety? And so they didn't really understand the importance of patient safety, or them being participants within their own safety. Even though we know that when patients are participants in their safety, it can lead to positive outcomes. So essentially, safety is not the patient's priority. That's one of the main barriers to patients providing feedback. In terms of facilitators, what we found is this idea about the individualised conceptions of safety. Now, we've already said a little bit around how patients, how staff have different perspectives of what safety means, but the same also applies to patient level as well. For some people, it was a very technical thing, very similar to the staff. For others, it was very much feelings-based. And then the second stage of the model, again, this one's quite self-explanatory, I feel, but essentially we need to provide patients with the opportunity and the ease to provide feedback. Now, to an extent we did it. We gave people the opportunity with the survey. We didn't give everyone the opportunity. It was only distributed to about a fifth of all patients. But I would also question whether it was actually easy for them to do so. It was a postal survey. And then the barriers. Some people had an inability to provide feedback, and there was also this real issue where people feared reprisals from staff. And again, that's quite a common theme with incident reporting. It's the same with staff incident reporting, where we have a blame culture within services. They won't report because they fear that it's going to come back to them at some point. And then on to the third part about how well it was integrated into the healthcare teams. So we can see the distribution rates by the different clinical areas. Cardiology had the highest, almost a third of them. But in total, 25% surveys were distributed. So it was a little bit disappointing. We were aiming for 100%, a very ambitious aim, but we're still the aim regardless. But what we actually found is that the engagement amongst the staff varied hugely depending on the ward in question. And to an extent, I wonder whether we ever actually got down to exactly why that is, what caused that variation in engagement. But what we did find is that among staff members, there's quite often confusion with other surveys. So for example, the friends and family test. Now, a little bit of background by the way, friends and family. When we conceived this study, friends and family didn't exist as a test. It hadn't even been discussed or thought of at all. By the time we got round to actually starting with the feasibility testing, the government all of a sudden decided, I know what we'll do. We're going to do this test. No evidence behind it, but we're going to ask people anyway for the feedback. And so that was implemented round about the same time that we started to implement this survey. And so when we were going into the wards, we'd be going in with the survey packs to be handed out. They'd be saying to us, oh, are these the friends and family surveys? No, they're not. So we found there was quite a lot of confusion, which possibly contributed to it. There was a lot of negativity towards friends and family among staff as well, as to whether it was a box ticking exercise. Whereas what we want to do is try and create, and try is the operative word, some genuine quality improvement based on what patients tell us at the local level. So there was that confusion. We found that distribution generally benefited from regular reminders, including from other staff, not just the research team. So we had quite strong links into the patient safety teams within the trusts, and they took on dare I say, the burden of walking around the wards, saying to them, have you been handing out the surveys? How are you getting on? Is there anything we can do? We also found that a single person with responsibility for distribution was also beneficial. And then in terms of the what they told us about the feedback in itself, they told us that, first of all, the quantitative data, they felt it was useful, but purely as an indicator. And so again, assume a little bit of background knowledge, there's a very big difference between a measure and an indicator. So an indicator is just basically giving us a little bit of a pointer, a little bit of direction as to where we need to look further, whereas a measure gives us more in-depth detail. So they said it's useful as an indicator, but actually it doesn't really tell us anything else that's needed to lead or to drive through any form of quality improvement. And what they felt was looking at the qualitative feedback from patients, not the interviews, but the free text comments that were included in the survey. They felt that those free text comments, they were the really important part for directing where they need to improve services. They also talked about what sort of barriers existed within in relation to distributing and using the survey feedback. And so they talked about time and resource limitations, which is quite understandable. Again, the study was conducted, and it still is, but through a lot of cost-cutting exercises within English NHS. So there were significant time and resource limitations, but there's also this reluctance to overburden patients with paperwork. Now, and also, I'm not sure if I say it, in terms of driving quality improvement, so this was all obtained from the semi-structured interviews, focus groups of staff members. But in terms of actually directing quality improvement, we didn't see any evidence that staff members were actually using it. So they talked about the potential for using it, but they never actually did it, which is quite interesting in itself. And it's something that, as of yet, we still haven't really broken the back of it as to how we can action the data that we collect to drive that forward. So when we were talking to staff as well, one of the things that they recognised is that, so at this point we had the data from the patients, and one of the things the staff recognised is that yes, the patients do see safety differently to us. So that was fine, we expected that. But what was interesting is that staff actually acknowledged that that would be the case as well, which I don't think has been published anywhere as of yet, but staff actually understand that patients will have different perspectives of safety to them, or different definitions will define it differently. What we also found when we were talking to the staff members is that there was this consistent focus on unsafe rather than safe care. Now again, just to delve into a little bit of theory, safety theory, then essentially patient safety, the entire patient safety movement, it started about 20 years ago, a couple of key publications in America and UK, that really introduced the concept of patient safety. There were safety studies done 30, 40, 50 years ago, Florence Nightingale and stuff, even further back. But really 20 years ago, there was a huge social movement to improve patient safety. And that social movement was basically based upon the systems approach to patient safety, or can be termed as the deficit model of patient safety, which really focuses on unsafe care. Why is care unsafe and how do we improve it? And it's quite a logical starting point. But recently, probably in the last 5, 6, 7 years or so, there's been a shift away from that. So that original approach is called Safety 1. Within those first 15 years, essentially we talked a lot about patient safety. We saw small bits of improvement here and there, particularly in England around infections was one particular one. But largely, if you conduct sort of a gold standard of identification of safety incidents, medical record review, there was no improvement over a 10, 15-year period, even though there's huge social movement, huge efforts. So there's a shift towards what's called Safety 2. And Safety 2 switches patient safety on its head. Instead of trying to look at unsafe care, it looks at safe care. Why is care safe and how can we learn from that? And the idea, in psychology it's termed positive deviance. The idea is that if we can identify somebody who's positively deviant, or might be a healthcare team or an organisation that's positively deviant, they provide the very best care that's given with the same resources as everybody else, then why is that? And that's the Safety 2 approach to patient safety. But what we found in our interviews with the staff is that when we presented them with those initial graphs, then only one person initially said to us, some of that's fantastic. 90% people think, 91% of people think hygiene's really good around discharge. Everybody else instantly looked at the negative. So that was quite an interesting finding as well. Staff also told us patients are important partners, and also this last point, some of the staff understood that patients feeling safe is just as important as being clinically or objectively safe. And for me, that's quite a big finding, because when I set out on this journey 10 years ago, my PhD was part funded by what was called a Strategic Health Authority, who had a regional oversight of patient safety, and I presented every few months at the board, and constantly I was asked this question: what does it matter if patients don't feel safe? As long as they're clinically safe, what does it matter? So for me, I was quite pleased to see that staff actually understood that feeling safe is very important, particularly in relation to patients' psychological health. So to summarise the findings, we found that patients were able to report the safety experiences following discharge from hospital, identify aspects of care that made them feel safe, but also patients tell us something different about patient safety from what staff tell us. And then we've got that model that we developed that can lead to increased feedback. And then there's also the fact that staff felt that the survey could be useful, but there wasn't any actual quality improvement as a result. So to try and amend that, we've got some funding at the moment. This is an ongoing study where we're trying to work with a very small number of care homes. So rather than the big scattergun approach of trying to involve everybody, we're working with a very small number of care homes, see if we can essentially create some form of quality improvement from the survey. Where we're at the moment is that we're hitting the exact same barriers we hit with our hospital staff around resources, availability of time, where we're finding that when we get the feedback, it's interesting, but we're not getting enough of it because the staff can't or won't incorporate the survey into the systems. But that study's ongoing. We're still trying to have quite a big push with that and try and amend it. So, and I'm really conscious of time, I'm probably overrunning a bit. Coming back to the safety incident data from the staff. So, we essentially did a search of the safety incident reporting systems. There was a matched period, so it was 12 months in total, and we identified 375 incidents that fell within the category of handover, transfer and discharge. 97 of those were excluded from the analysis. They didn't relate to a patient transition, they weren't a patient safety issue, or there were some duplicates as well. So for example, not a patient safety issue was where a staff member had fallen over and hurt himself whilst they were transferring a patient. The patient was never at risk, therefore it's not a patient safety issue, even though the staff member was harmed. So we looked at 278 incident reports. In terms of the categories, we found the vast majority of them were related to pressure ulcers. And I'm going to focus mainly on pressure ulcers because it really gets across the message from these incident reports. We're almost at the point of submitting this paper publication as well. So 101 safety incidents related to pressure ulcers. Now, when we look at the levels of harm that staff reported, so they report different levels. They can report no harm, low, moderate, severe, and death as well. What we found was that, so the black bars related to what was reported by staff. What we found was consistent underreporting of harm. And a lot of these fell within pressure ulcers. So this isn't just discharge, by the way. This is related to internal transfers as well, so somebody moving from one ward to another. It could be discharge, it could be people moving from hospital to hospital as well. But there was this consistent underreporting of harm. So for example, somebody with a stage 3 pressure ulcer, so quite significant harm resulted to the patient due to their care, would often be reported as no harm by the staff members. And the reason being is that when it comes to transfers of patients, essentially there's a question mark around who owns the safety incident. And so a lot of these reports were from people who working on a ward, patient was transferred into the ward, and they see, oh, the patient's got stage 3 pressure, so this is really bad. Nothing in the patient notes, fine, I'm going to report this. But because it hasn't happened on my watch, our ward doesn't want to own that safety incident report. So I'm reporting it as no harm to the patient. And essentially they've been quite selective in how they report it, saying that, well, actually, we don't own the harm to the patient. We own the patient and I'll report the incident, but we don't own the harm. And for me, that's wrong. So significant underreporting of harm. Almost all cases, 98% that had to be regraded when we looked at this were all regraded up, not down. So it's definitely underreporting, not overreporting of harm. And essentially what we found is that as well as this issue around ownership, it's this second point. These incident reports were being used essentially as a defensive mechanism to try and protect the team or the ward that people worked in. So we know that there's issues when it comes to staff incident reporting around professional identity. So when we talk about blame culture, then we see the doctors will try and protect other doctors, nurses protect nurses, etc. We see the same within teams as well when it comes to reporting of harm. We also found this one. So in the English NHS, there's now a duty of candour, where, if I remember correctly, it's anything with severe harm or greater has to be reported and the patient has to be informed as well. Now, what we found is, and I can't remember if I've included, no, I didn't include the data in the slides. What we found is that throughout all of these incident reports, I think, if I remember correctly, there were only 11 instances where, as part of the actions taken as a result of the incident, there's only 11 instances where the family member or even the patient was informed. Now, bear in mind, some of these are quite severe harm, although they were underreported and staff didn't think they were. Even still, for me, if somebody's been harmed by the healthcare, there should be some element of trying to involve them, even if it's trying to work out what it is that went wrong. But there was pretty much none of it happening. So, I have overrun a little bit. So, essentially, that's the stuff I want to talk about post-hospital patient safety, or related to discharge, transfers, handovers. So the next bit of presentation, it is shorter, it's not going to take 50 minutes. But the next bit of presentation is pre-hospital care. And this is another one of my real interests. So back in 2012, finished my PhD, went down to York St John University with my supervisor to work on a really small project looking at frequent callers. And as part of this, when I first started it, we set out not knowing anything about the topic. And I wanted to find out, okay, what is actually known about frequent callers? And the answer is right at the start, very little at all. This 2012, published 2014, that still applies now. Still very little is known. So we found that there was no standard definition internationally, so no two studies actually use the same definition. We actually only found 7 ambulance service specific papers as well. 11 other services that mentioned how patients arrived at the hospital. Essentially studies of frequent emergency department users who arrived by ambulance, but ambulance was not even a secondary outcome of an intervention. So we found no studies explored characteristics of frequent EMS callers, only users of ambulances. And I want to differentiate between the two because I think it's an important differentiation in that when we talk about users of ambulances, it's people who have been transported or conveyed to hospital. Now, I'm not quite sure how the ambulance service is set up here, but I believe it's very similar to how it is in the UK, or at least in England. But we have a really big push on see and treat and hear and treat. So people who will be treated via the telephone, or paramedics will attend on scene and treat the patient and leave them where they are. Whereas all of the studies we found in the review only looked at people who were transported to hospital. And that's not the majority of patients, certainly not the majority of frequent callers. So none of the studies actually took quite a wide view. Huge range in number of patients who are frequent callers. That's down to the definition. Different definitions give you different answers. Frequent users more likely to suffer from non-trauma events than non-frequent users. That's a very important one, particularly in terms of how urgent care is delivered in a pre-hospital care setting. And frequent use of ED are more likely to arrive via ambulance than non-frequent users, except paediatrics. But again, little research. Gender and age, very confusing picture. We still don't know much about it. A couple of studies said more likely to be male, one said female. Essentially, we don't really have a firm answer to this. And I'll give you some, I'll talk around this in a second properly. Likewise with age. Ethnicity, this is really big focus in US studies, basically. Not so much in studies elsewhere. Same with socioeconomic status. Time of use, it's an interesting one. I'm going to talk about time of use properly shortly. So did this systematic review, and then we also did an analysis of top 100 callers to Yorkshire Ambulance Service, top 100 frequent callers. Now, note the definition. That definition doesn't apply nowadays. At the same time as this, what we did was we set up a National Ambulance Service group that looked at the management of frequent callers across, started off across all of English ambulance services, and then we've also now had involvement of Scotland, Wales, Northern Ireland as well. And as part of setting up that group, we've set a standard definition of frequent callers, which is set I'm trying to remember what it is, 5 calls in a month, 12 calls in 3 months, either or. So that was set up, that's built into the ambulance quality indicator now as well. So take some of these findings with a pinch of salt, but still tell quite an interesting story. So we looked at almost 8,000 calls made by the top 100 callers. Now, you might think that's a lot, but it's not. Using the new definition, for example, I've seen one frequent caller who one ambulance service called 2,000 times a year. The norm for the top of the range is about 800 calls on average across the ambulance services. So you do get quite a large number. So as you can imagine, the costs associated with frequent calls is potentially astronomical. So as part of this study, we did population comparison, we did a little case control study, and multiple regression analyses of the calls. Now, time of the calls. So there's a second line, I'm not sure if everyone can see it, but it's grey, that runs behind. So this is really interesting. So the black line of frequent callers, grey line is the rest of the population that call the ambulance service. So millions of calls in comparison. And you can see a very clear pattern where frequent callers, essentially up until about 8 o'clock in the morning, called more often than the rest of the population, and that dipped until roughly 4 or 5 o'clock at night. Now, it just happens that those are the same times that GPs open. So there's a really strong correlation there between access to other services. The only exception to that is this one, which is roughly, it's quite hard to see in the graph, it's roughly about 11 o'clock at night, which is pub kicking out time. So, very interesting story. Essentially what we can see from that is that it's related to access to other services. And it's one of the assumptions that we made within the national group and within all the research we've done, is that these frequent callers, they are absolutely not vexatious callers. They are people who call because they have some form of unmet health or social care need, or both. Vexatious callers get managed through an entirely different stream to the way frequent callers do. So there's legal proceedings that can be enacted for vexatious callers. So people who are calling to be a nuisance. These aren't. These are people who are using the ambulance service as a means of last resort. We also found increase during winter months as well. And when you think of how overburdened services are during the winter anyway, this just exacerbates the problem. So again, what we found in terms of the urgency of the calls, essentially the higher up you get is less serious calls. It's suggesting that the black bars again relate to frequent callers. In comparison to the control group, in this case, a matched control group of 100 patients, more likely to call for less urgent reasons. So this is very much around urgent rather than emergency care. And then in terms of the actual call reasons, so if anybody knows ambulance service data, it's very limited in what it can tell you around why people call. I know the Irish Ambulance Service uses the same triage system that Yorkshire Ambulance Service uses, AMPDS. But what we found was most frequent callers, abdominal pain, breathing problems, headache, and then psychiatric and sick person were all related to frequent use. Sick person is a horrible category. It is a catch-all term for somebody who's generally feeling unwell. Again, it's suggesting that there's that urgent care need in there related to chronic conditions rather than trauma events, essentially. And that's a huge one around mental health, also has a large part to play in frequent use. So that's multiple regression analyses. So where we got to is that, so we've now identified the problem of frequent callers. It's due to unmet health social care needs, but how on earth do we deal with that? Some of the early conversations we had within the national group was essentially around, as an ambulance service, is this our job? Should we have responsibility for these patients when really it should be their GPs who are looking after them. So is it actually our responsibility? But ultimately, the patients are using the ambulance service as a means of last resort. So therefore, we've got a responsibility to do something about it and provide the best quality care that we can. So the research around clinical case management in EMS, emergency medical systems, is again virtually non-existent. When we did the systematic review, 3 studies came out. Interestingly, so the first one found that ambulance use increased as a result of clinical case management because it was an ED-based intervention. So what they wanted was to essentially shift the burden away from the ED to the ambulance service. And they were successful in doing so. But actually, is it the ambulance service's job? Second one had a very small number of 10 frequent users. There's not much you can really say about that, but they did see reduced calls and also cost savings. And then clinical case management in BD as well. Really interesting. It took me a long time to try and work out what they're actually reporting. Reduced median ambulance cost by 50%, but very significantly not significant. That's the right way of saying it. And essentially that's because they were looking at, in terms of a statistical analysis, the cost per use. So essentially when they did the statistical analysis, although median ambulance service cost reduced by 50%, each transport still costs virtually the same amount. Well, of course it will. So I don't really understand why they even did that. So in one case study, this is London Ambulance Service. They looked at 110 patients who were enrolled in case management. So I had the opportunity to review it, and I also wrote commentary around this paper. And some of the interesting things that stood out for me is that, first of all, we can see roughly 50-50 male-female split. Slightly more towards female, but I think that's just due to the low sample, low participant numbers, and then the age as well. So huge age range. So again, still that same message, is that the frequent callers are a very heterogeneous group. So what they found is that 64% had a frequent clinical or medical need, 40% with acute or chronic mental illness, 38%, it's supposed to say older, used their language in that, and then 28% the unmet social personal care needs. So again, what we essentially now do is say that we can group frequent callers into one of 3 categories, or a combination, is around physical health, mental health and social care. I do have an excellent anecdote, but I'm being recorded, so I'll talk about it afterwards. And with these 110 patients, you can see each one of these is a different type of intervention, and they've staged them in terms of essentially the number of resources that can be used. So initial stage is evaluation and 6-week review of a patient. And then the second stage is contacting the patient's GP. But you can still see there's 10 different interventions. And this really builds on the idea around collaborative working within a pre-hospital care setting, in that even if we do take, as the ambulance services, we do take responsibility for these patients, it's not an individual endeavour that one ambulance service can undertake. It needs that multidisciplinary team working with GPs, social care, mental health care teams, sometimes police force as well. They've got quite a lot of involvement. So these are a very, as one group, if we can call this one group of people, a very, very complex group that's very difficult to try and understand. 91 to 83% of patients receive more than one type of intervention. They did find, as a result of the intervention, significant reduction in calls. And it's a very promising finding. The reason I'll only describe it as a promising finding is they didn't consider regression to the mean. And if anybody who's not familiar with that, It's the idea that as you measure something multiple times, it will return back to its normal point. The normal point is being a non-frequent user, non-frequent caller. So one of the large contributory factors, for example, is, quite frankly, if a patient dies, unfortunately, then their calls will regress back to the mean. Most people don't call the ambulance service. And I would probably expect, there's no evidence within this data set, but I would probably expect somebody who's been identified as a frequent caller, probably about a quarter may die before they drop off the system, with the rest actually dropping off as a result of intervention. So, almost finished now. In terms of where we are at the moment, so this started off 2013 with the national group and the research. At that time, every ambulance service had a different definition. There was an ambulance quality indicator and for frequent callers. Anyone familiar with quality indicators will know they have to be very robust, and the AQI for frequent callers was awful, to the point where only 5, I think, of the ambulance services bothered even reporting. Their numbers they reported were based on different definitions, and it meant that you had huge variance in reported calls. One ambulance service, when I looked at the AQI data, said they had 50 calls from frequent callers within a 12-month period. Now, if you think, that's probably about 4 or 5 frequent callers. It might even just be one. Whereas another service said they had 5,000. And actually, the numbers have greatly changed because we changed the definition. So as a result of that, we started identifying where best practice existed. London Ambulance Service, in particular, in this case study, have generally got the most established frequent caller team. Other services had different approaches. So I'm sure they won't mind me saying, even if this is being recorded, North East Ambulance Service had essentially a, what's the proper term? Customer relations manager dealing with frequent callers, and the route to identification is different. So London Ambulance Service, Yorkshire Ambulance Service, very quick in setting up automated systems that would identify frequent callers. Again, North East Ambulance Service, they relied upon referral from call handlers or paramedics. And the problem is, essentially, you'd get a paramedic who would go to the frequent caller team saying, look, I've seen this patient 20 times in the last couple of weeks, will you please do something about it? But it's not a guaranteed way of identifying everybody. So there's been a huge shift. Virtually all ambulance services now have got a dedicated frequent caller team, and virtually all of them will clinically case manage patients. But this study is basically the only evidence we've got to say that it works, and it's not a perfect study by any means. So where we're at now is essentially the study, it's called STRETCHED. Don't ask me what the acronym means. But essentially it's been led by Swansea University in Wales, and I'm one of the co-applicants on the project. And what we're trying to do is look at the effectiveness, safety and the efficiency of case management for frequent callers. So there's different work packages. We're looking at building a logic model around what current practice and new models of care look like. We're looking at creating natural experiments to evaluate clinical case management in 4 of the ambulance services, which will hopefully cover various different geographical regions as well, so including urban, rural areas. And we're going to be looking at the epidemiology of frequent calling in a lot more depth than we have so far. Looking at evaluating models of care, clinical case management, as well as, and this is probably for me one of the most interesting bits as well, the interviews, particularly with the callers themselves. Why is it, from the frequent caller's own perspective, that they're using this service so much? Where are the gaps in the delivery of care across the entire healthcare sector? This isn't an ambulance service problem, this is a health system problem. And we want to tie all of that together. Now, just to give a bit more detail as well, this is not an issue that's unique to the UK. Guarantee it. I've looked at data from Spain in Malaga. I've looked at data from New South Wales in Australia. They have the exact same issue, regardless of how ambulance services are funded. There's some papers that touch upon it from America. I've had colleagues in Finland who said we've got the same issue as a German paper. This is an international problem amongst ambulance services. Now, to an extent, for people who are particularly statistically minded, then it is impossible to eliminate frequent use. It's absolutely impossible statistically to do so. You will always have variation in calls. You will always have people who lie 3 standard deviations plus outside the norm. So it is impossible to fix, but it's not impossible to improve. And that's what we're really trying to do now, trying to improve practice by understanding very much in depth. There is also going to be hopefully a health economics component to this project as well, which will really tell us the cost. But one of the challenges, don't know if anybody's done research or worked with ambulance services here, is actually we may be able to improve the care patients receive. We might be able to reduce the service usage of the ambulance service, but are we actually reducing overall health system use, or are we just shifting the burden somewhere else? Are we shifting it somewhere more expensive? Should we be doing it? Or is it going to cost more from a financial perspective anyway? So huge questions that still need to be answered. But that's where we are now with frequent callers, looking at pre-hospital care. So very quickly, just to finish off, just to say a few thanks. First of all to Aoife for helping to host this. Thank you very much. And then various different funders and collaborators. So yes, thank you.